Hey everybody, Karen Anderson with Aortic Hope for tonight's Ask a Doctor event. So before we explain what that is and get started on talking the night away, I need you to click like, click subscribe, click that little bell so that you're notified every time we go live, like an event like this. I mean, there's so many different things that we do that are live, from Qigong every Sunday at 12:30 to Aortic Artist, which is coming up next week, I believe. I don't think it's this week. No, I think it's next week. Um, and then we have the Aortic Kitchen, and that happens usually twice a month. So that's going to be starting again. Live interviews with physicians, with therapists, with even attorneys for disability. There's so many different things we do. Live Survivor Series, live weekend review every week. So if you click the bell, you'll get that ding and it'll tell you, hey, Aortic Hope is live. And you don't have to remember what we're doing, right? So tonight, what is Ask a Doctor? So it started off as something back in 2018 that we strictly did on Facebook, but now we're kind of simulcasting it. It's happening in two places. It's happening here and it's happening there, primarily there. So if you have Facebook, the top of our page is a post with a big burgundy square. It says live, and Dr. Prakash's face is right there. All of the questions that you want to ask Dr. Prakash, you can start loading up in the comments section. Be mindful, this is a public page, so everybody's going to be able to see however you've logged into Facebook and your question. Okay. If you want to remain anonymous, there should be an anonymous link below my head that's talking to you in the text and information. Click on that link. Okay. And then you'll be filling out a form and we will ask the question for you. Uh, as he is answering questions, I'm going to be reading them to all of you and giving you the answer, right? And if you want here, you can put questions down in the chat. Same rules apply. This is public. This will be living out here forever. So if you want to remain anonymous, use that same form, and I will move that question over to Facebook and then read you the answer when it comes in. At least I'm going to try to juggle this for an hour. I usually have a sidekick. She's not here with me tonight. We'll see how long my voice lasts. So it's just me. It's just me entertaining you until the doctor joins us and until I give up at 7:30. But he's going to be going on until 8:30. So any questions we forever, whatever reason, don't get to that you post there in Facebook will be answered there in Facebook. And he usually goes back the next day and looks if there's a few that have trickled in, and he's very good about answering them. So that is what's happening tonight. We already had 10 questions going in, so it's already going to be a very busy evening. We will look to see if he's on with us live now. Sometimes he is, sometimes he isn't. Nope, he's not there yet. He's a doctor. Things happen. What can I say? So in the meantime, I'm just going to use this as commercial time. Hey, like that. I'm going to do my first commercial PSA, and then we'll check to see who's there. Hey, you guys, look. See Aortic Dissection, the Patient Guide book. We still have these available. They're still flying off of our virtual shelves. This is something that you can download for free. Download for free. If you're looking for a hard copy, I strongly suggest you mention something to your physician, because we will send a box of 25 books to your physician for free. No cost involved. And then you can get your free book, right? So talk to your physician and be like, hey, I want to get my hands on an actual copy of this book. And there's a link on our main page of our website. There's a link under resources, and there's a link on Hope Shop page. You cannot miss this link anywhere you look. All right. It's a link in Instagram. It's a link on Facebook. Tell your doctor to fill out and click the link to have a box of 25 books sent to their office. This book was written by patients for patients and caregivers. It was then clinically reviewed and then given the very strong endorsement by the Society of Thoracic Surgeons and Society for Vascular Surgery. Takes a lot to get those endorsements, everybody. It's such an easy to read book. It was a combined effort from Think Aorta US and Aortic Hope. Started off as a concept from our friends from ADA UKI, otherwise known as Aortic Dissection Awareness UK and Ireland. They created this idea, and when I saw it, I cried. That was my first reaction because I thought to myself, gosh, if that book had been available when I had my dissection 10 years ago, I know for a fact my recovery would have been a lot easier. 100%. Pretty much A to Z. Everything you want to know. What is the aorta? What is a dissection? What are the different areas that it happens in? What is the way to diagnose it, to treat it? What is the way to continuously monitor it? What are those different forms of testing? What is the genetic component with this? What is it as from a mental health perspective, exercise, diet, medications? What are they and are there side effects? Why are they being used? Emotional support, all of the support resources, pictures that your physician can doodle in there and show you what they've done, questions. So many questions already exist that have been created by patients for patients to utilize pre-op or post-op. With this book, it's going to be post-op, obviously, because a dissection is an emergency event and it's not a predetermined surgery, right? But there is no reason that you need to have one-on-ones with anybody. Check out the book and learn about these questions, okay? They're already right there in the book. So again, no cost. If you're someone who's about to have surgery, you can click on the link for a care package from us. That's underneath our programs. You click the link for care package, you're going to get a copy of the book, because when you have open heart surgery, 99% of that information will be applicable to you as well as far as your recovery. Now, the good news is book number 2, ding, 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 has already been written. It has already been reviewed and it is out for endorsements right now. And that book is called Aortic Disease, the Patient Guide. What is the difference? The difference is we know that dissections are rare and aortic disease is much more common than you think. So what that book takes you through is the aorta, its own organ. What are the zones? How do we determine if somebody has an aneurysm? Who's at risk? What would be the monitoring of an aneurysm? What's the treatment plan? What's the recovery? What if you have aortic valve disease, regurgitation, stenosis, or you're born with a bicuspid or anything that's not a tricuspid valve, aortic valve, right? So what does that look like? What are the treatment options and when? What's the recovery look like? Genetic issues, emotional and mental support, exercise, sex, diet, all kinds of stuff, travel, dental procedures, everything that you can imagine is in there, including the support and the emotional resources that exist within the community. Also some doodling that you can do back there, and all of your pre and post-op questions and suggestions. That's in the second book. So it's a little bit bigger, covers a lot more people, but we are hoping to get that QR code to you. I'm hoping by the end of April, but doctors are kind of hard to get in touch with to get that endorsement, but it is worth waiting for. And it's going to be a book that's worth waiting for. Again, written by your peers and clinically reviewed by many doctors, of whom you probably know some of the names. And when we get those endorsements, we'll be so proud to share that with you. So that's my PSA, number 1 for the night. Yay. Who's with us, Josh? Anybody for me to say hi to?
Well, let's say hi to Christina, Tom, and Ryan.
Hey, Christina, Tom, and Ryan. If
Ryan
it's Ryan
says,
Rodimer,
yep,
he's one of our authors in this book who helped us out with the genetics section. Thank you very much.
he's genius. He owes me time. He
He's been a little
says,
busy.
I know. He says, hi, everyone, hoping to stay for a bit. See how busy he is?
It's busy. I'm still waiting to see if the doctor has joined us. So I'm going to send him a quick message and just say, hey, don't forget. All right, we are live and questions are waiting for you. Okay, this is when I guess I have to start doing jazz hands, right? Because no, you know what I'll do? I'm going to triple check here and make sure that all of these comments were things that we've shared. And they are, and I'm sure he'll be on any moment because I did that entire PSA in 9 minutes. But again, it's a doctor. We got to bear with him, right? And just wait for him to join. But don't hesitate putting your comments or your question in the chat below. If you're watching here, please do so. And if you are also on Facebook, go ahead and put your questions in Facebook. Okay? Just start doing them. He will catch up. He's pretty fast. So, my second plug for the night, you guys. The card decals. The card decals. I love when someone sends me a picture of their vehicle and they've got their decal on the back. I just find it very exciting. These are awesome because these are like window clings. So they're very, very easy to put on. Also very easy if you want to take off. Look at that. So you can't really see it, but it does look great. And it's very easy. Just put it right on the window, peel the other sticker off, and you're fine. That you can get with a $5 donation. It's right on our Hope Shop. Just scroll down to like the second link. that has pictures of the belts and the magnet. Click into that link and you'll see it's like an order form and you can order those decals. So I do suggest that you take a look at that. And while you're there, you're going to see our magnet. This is the awareness ribbon for aortic disease. And these magnets are $10 donation. These are very thick, very sturdy. I don't know how many cars still are magnetized right now, probably by the gas tank. And maybe there's a spot or two on bumpers. I don't think they make them where you can really stick a lot of things on them, but they still are great. I love taking them. And then, like, if I go to make a visit at the hospital, I just slap them on the back of ambulances because why not? Right. And then again, when I'm in the community, I love seeing them on a car. It's usually Tammy from our board who happens to be in town. But every time if I run into her car and I see it, I get so excited. I'm like, oh my God, there's somebody new. No, it's not. It's Tammy. But it's still thrilling. It's still thrilling. So, yeah. Hmm. Guess I have to slow down my PSAs until he joins us. I love filling air, filling
Well, we
time.
have some new people to say hi to.
Oh, that's awesome. Let me write down their names. Who is it?
Okay, hi. Carrie Hendrickson from Kauai.
Hi.
I said aloha. I know, right?
Aloha. Ooh.
We have Misty Hunt from Nevada. Hi. Hi, Misty. Thanks
Hi.
for joining with us today. And
So
Alan
wonderful.
Martins. Hello, Alan.
Hello. Thank you guys so much. Oh my gosh, Kauai is the next island I have to visit. I have been to Maui 3 times, Oahu twice, and Kauai is my definite bucket list of my next venture out to Hawaii, which may be next year or definitely by 27. So I love Hawaii. It's one of my favorite places on earth. My second is Greece. It just is. Not that I've been to that many places, but gosh, Hawaii is like, for me, if you fly in at night, it's because it's dark. It reminds me of the scene out of Wizard of Oz where everything was black and white, but then when you wake up in the morning, it's like when it turns color, and it's just beautiful. Oh, so beautiful. Gets me all like verklempt. All right. I keep checking, but you know what? I'm going to give you guys some ideas of what these questions are because they're so intriguing. And maybe we'll play the game. Karen can guess if she knows the answer until he joins. Okay, let's see where he is. I'm going to check him again. Well, it says it was delivered. It says my message was delivered. Maybe he's trying to log on to his Facebook. Okay, so some of the questions, and some of these I pulled from some of the pages, and maybe these will spark questions in you. And I apologize that he's not with us yet. I know we're running a little late. It's 15 minutes, but he is a doctor. Again, these things, they do happen. So one of the questions was, which if you're on Facebook, you can see all of these. So does it seem normal to have had an echo 6 weeks ago? This is interesting. And it said the ascending aneurysm was 4.2 centimeters, but like the other day, a CTA was done and it says it's 5. Not sure if it was gated, but that's scary, you guys. 8 millimeter growth in like what, 4 to 6 weeks? I feel like that's kind of unheard of. And I feel like somebody made a boo-boo. That's my personal opinion. I kind of look at it like, well, maybe it should be redone. That's what I would be saying. Can we redo one or the other? I don't even know when an echo would be almost a full centimeter different than a CTA. Like, that just seems like it's grossly under measured, right? Something seems a little off. Or maybe the 5 centimeters was length, because that can happen. So I don't know. Questions about fenofibrate. That's a drug that can kind of help with cholesterol if that can cause cramps or joint pain. That'll be interesting because I don't think that's considered a statin. Another great question, how long does it typically take to recover from open heart surgery? While I have people out here, why don't you chat with me and tell me how long it's actually taken you guys? I tell people it's a marathon, not a sprint, and that is probably got to give yourself, we know 12 weeks for the sternum to heal, right? I say give yourself a year because if versus open heart surgery, if it's an emergency like a dissection, I kind of feel like there's so many other issues that are going to be in play emotionally and mentally, and just getting used to what your body feels like. Um, that it could take you a year before you really get used to the skin that you're in, right? And a lot of people have said it's like a 2.0 version of yourself. So you have to be kind. You have to be kind to yourself, I feel. Another question that's been asked is it normal or heard of to have a second dissection? Hmm? Hmm? I would think if I'm split all the way down from top to bottom, I don't think I stand a chance to have a second dissection. But I mean, if you consider a tube, I'm sure you can cut one area and then you probably could cut another area. So I'm not a doctor. What do I know? I do not know. But my answer would be, yeah, probably. But I don't know. But I can't wait to find out. Somebody else had an interesting question that said uh, this person was told that their blood type is A negative, and that could have been a contributing factor. Plus, having COVID could have been contributing factors to a dissection. And my guesstimate of an answer would be um, that COVID in and of itself probably did not cause a dissection. But if you already had underlying factors that caused a weakened area in the aorta and your heart is working super fast and hard to rid itself of an infection, that maybe then that could have been like that extra added icing on a cake of, rest of ingredients to make a cake, and it just said kaboomy, right? So I don't know, maybe, but I don't know about the A negative. That would be very interesting, right? Be interesting. But my guess is we might be having an answer. We do. We have answers, you guys. It's so exciting. Okay. Or there's more questions one way or another. It's very exciting. All right, let's go. Let's read some of these answers. Let's see what happens. Okay, looking for answers. Do. All right. First one, could CoQ10, have you guys heard of CoQ10, be an option for cholesterol or muscle pain? Interesting. And the answer from the doctor, from Dr. Prakash, is yes, for some people, coenzyme Q10, which is what CoQ10 stands for, can relieve muscle pain caused by statins. So it doesn't work for everyone, but it can be worth a try if you really need to take a statin and you end up having muscle aches. So everybody take that answer to the bank. All right. Next one. He's catching up to us. Why would atorvastatin, if I pronounce that right, atorvastatin, we'll see, I butcher, be prescribed, and can it cause muscle and joint pain? And he says atorvastatin is prescribed to lower a type of bad cholesterol called LDL cholesterol. LDL cholesterol builds up in the arteries, which can actually cause blockages that can lead to heart attacks or strokes. And one side effect of that drug or other types of statin medications is that they do cause muscle aches. Sometimes people have to stop taking this drug because the muscle aches become really, really severe. In almost all cases, stopping solves the problem and there is no permanent damage to the muscle. So that is good. Okay. What are some of the types of medications commonly prescribed after a dissection and why? That's an interesting question because I know there are some people out there that actually are not on any meds, which blows my mind. Okay. The two most commonly prescribed types of medications after a dissection are beta blockers, check, like metoprolol or atenolol, and angiotensin receptor blockers, which are ARBs, like losartan. Both are types of medications used to treat heart disease or high blood pressure, but they just work completely differently. Okay, beta blockers work. And get this by slowing down the heart rate. So think about this. If you're on heavy doses of beta blockers and you're wondering why you're out of breath or you're fatigued if you try to work out, ding, ding, this could be a reason why, right? So I know I had this conversation with my cardiologist when I'm about to get ready to go back to the gym and try again. She reduced my AM beta blocker so that I wouldn't have such a slow, and I'm talking, I average about 50 to 55 heart rate, not resting, like up and moving. So you can only imagine if I'm trying to like work out and I'm working against the meds, it would be difficult. So we reduced that so I can get my heart rate working. And so beta blockers slow down the heart rate and decrease the force of ventricle contractions. So that reduces the wear and tear on the aorta with every single heartbeat. Angiotensin receptor blockers, or the ARBs like losartan, they work by reducing blood pressure and decreasing the release of certain stress chemicals that can increase the breakdown of aortic tissue, which is why so many of us tend to be on losartan. And there was a big brouhaha when I think it was valsartan was recalled. There was a lot of recalls that happened one year by the FDA, and it was really just a certain, I guess, number on the box or whatever batch. But these are very important medications that you should be taking. Um, if they're prescribed to you, you need to take them. That's the bottom line. If you have questions about those drugs, you want to talk to your physician. Okay, here comes some more. No, that one wasn't answered yet. Okay, let's try. Let's refresh because I keep seeing little things that ding, he's answered, ding, he's answered. All right, let's see what else we got here. Do. Oh, yeah, he's
Oh,
catching
we
up
have a little bit
for
of
sure.
feedback here in chat.
Oh, please. Okay.
Velda has joined the chat. Natalie
Hey,
has
Velda.
joined the chat.
Hey, Natalie.
Alan says, if you like the Hawaiian Islands, you need to visit the Azores.
How far away are the Azores?
Yeah, I don't know.
And as long as they don't have giant spiders, I'm all in. All in.
I like that.
Yeah.
Alan says, never trust an echo in the chest. Yes, they're usually different, but that's a big number.
It's a big difference, right? Like, I mean, I get my echoes because they want to see how my valve's working, and they do give a number on the aneurysms that they see, which is really pretty much ascending and the beginning of descending in the arch. But we primarily go with my MRAs. I can't do CTAs, but right. But they should not. I mean, a millimeter or two, sure, but 8, come on, that's like something's not right. Right, something's not right.
Right, and so Velda says a year. I agree, Karen.
What'd I say about a year?
About when you're getting used to being in your skin again.
Recovery. You know, I'm into my voice again because I kind of like the way it sounds when I laugh. All right, here we go.
Hold on. And so Misty posed a question in the chat. She says, what about the other statin, rosustatin? Probably spelled that wrong. Is that better versus aorvastatin? I can't spell today. And I passed that question into the Facebook Q&A for the doctor. And then
see that.
She follows up with, does beta blockers as well lower BP correct? And I did. I went ahead and posted that.
Perfect.
So to finalize chat here, Alan says, remember, there was a study that suggested that lorzastatin lowered the chance of your aneurysm to grow. Who knows if it works, but I'm going on 16 years of no growth ever.
Good for you.
And then he says
awesome.
He's 4 hours from Boston, the Portuguese equivalent of the Hawaiian Islands.
That's where you are, or that's where it is?
I think that's what he was answering, where the Azores are.
Oh, interesting. Okay. All right. Back to the questions. Thank you. Is it normal to have another dissection after the first? Scary question, but here's the answer. It is not normal. Yes. I was hoping for that. To have another dissection, but it can happen rarely. So it doesn't mean no, but they're not saying it will happen. So this is one reason why the cardiologists recommend lifelong monitoring of patients with aortic disease. And that does make sense. Okay, going for the next one. Oh, okay. The individual I told you about who said that their blood type is A negative, could that have been a contributing factor plus they had COVID? And the doctor says COVID and A negative blood type are not known risk factors for aortic dissection. So that is don't drink Kool-Aid. Ask your physician for the answers to these questions. I've heard those things out before, or I've heard taking a vaccine gave you a dissection. That is not accurate. Okay, here's the answer to the question. Had an echo 6 weeks ago, said the ascending aneurysm was 4.2, but the CTA that she just had says 5. If it wasn't gated, should I ask to have either test retaken? And the answer is, it is common for CTA and echo measurements to disagree on the aortic diameter, but that is a very large difference. Alan, did you read that? Did you read that online and then you just acted like you just came out with that line? Because that's exactly what the doctor said. No, I'm only kidding. One reason that it can happen is that the echocardiogram may not have imaged the largest part of the aneurysm. Okay, that makes sense. If they missed the largest, then they would have missed the 5, right? But the echo really only visualizes this relatively small part of the aorta, which is the part that's going to be closest to the heart, hence the root or the ascending. And if the aneurysm is farther away from the heart, which hers isn't, it's really truly on the aneurysm, on the ascending, then then can be imaged using an echo, the echo measurement may underestimate the size of an aneurysm. So no answers to if it should be retaken. I guess that's one for the potential surgeon to determine, right? To be determined. Okay, next.
Alan has a question
Yes.
here. He says, why
Okay,
can't it happen? Remember, you don't need to have an aneurysm to dissect.
this is true. It's just not that it can't, it's just very rare.
I think
It's
this is
rare.
bound to your genetics.
Probably bound to genetics, right?
Yeah.
And if you have underlying comorbidities,
Mm.
so you have an immune suppressing uh, issue and your inflammation markers are really high,
Mm-hmm.
that can cause an issue. So if you're predisposed to having weakened areas of your aorta, just weakened doesn't mean a bulge, like if
Yeah.
you have Marfan's or something like that, right?
Yeah. And like, some people get that dilation and that's it. That's the dilation that they'll have for the rest of their life. There was this one
Mm-hmm.
thing,
And then nothing happens, right?
Yeah.
So who
Yeah.
knows? All
So it
right.
runs
So
the
a
gamut.
person says, yep, their balance has been off 4 years later from having a dissection. It comes out of nowhere, just kind of hits them. Could it be medication and pressure? And so other types of balance issues are not associated with these symptoms and should be checked out by a neurologist. Would not be related to your aorta and your medication. Okay. Next one. We get this often. Can a dissection heal itself? Right? And the answer, which will have an explanation, the initial answer is yes. What does that mean? Dissections that do not extend through the intimal or inner layer of the aorta can heal themselves. Hmm. Sometimes they find evidence of old healed tears when they examine aortas of people who have had aortic surgeries pathologically. Do you know? I love learning something new. I did not even know that. But I guess that kind of sort of makes sense because maybe they heal like they have a little clot. I guess it would be like any cut, right? You can clot them off. Maybe they're not just flapping, right? It wouldn't come back showing that there's a dissection flap. But interesting. So as long as it hasn't gone through the inner layer, if it's in the outer layer or the middle, but it hasn't gone all, I don't know. That's interesting. I'm gonna have to really sit on that one. I'm gonna sit on that one and think about it. Okay. Do we read that one? We read that one. We read that one. I'm marking the ones. Can fenofibrate cause foot cramps? So fenofibrate is a medication used to treat another type of high cholesterol called triglycerides. Foot cramps are not a common side effect of fenofibrate. In most cases, they'd be caused by something else. And I'm not a doctor, but my guess would be low magnesium, maybe, right? I think everybody knows have a couple bananas or take magnesium supplement if you're having cramps or you could be dehydrated. So there's, a couple different reasons why you could be having cramps. Okay. Oh my gosh, there's so many things here now. Blah, 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 blah. Oh, no, there isn't because I have to remember how many questions are up and then double it because the answers, well, I get overwhelmed. All right. We have a lot of questions and answers coming in, and then we'll see what you guys have to say. All right. Do. Uh, we know BP, having it be low is important, right? But what about heart rate? Sometimes this person's heart rate is in the 90s to 105 resting. Oh my goodness gracious. So, heart rate is highly variable. We know this because you could be watching a scary movie, a love story. You could have just eaten something and your heart rate's going to go up, even though you think you're at rest and you're just sitting there. That's not what's going on inside. There's definitely a mind body connection. So you really don't want to look at your heart rate because you think you're resting, but you just ate 15 minutes ago and just had a huge, gigantic steak, right? Because your heart's going to work harder to digest. Not your heart's not working hard to digest, but your digestion is happening harder. And so therefore everything is working harder and your heart rate probably will be elevated. But so if you think about the course of one day, and it depends on factors like your age, your level of physical activity, I mean, your heart rate fluctuates all day long. So if your heart rate is higher than normal for you, um, and there's no obvious cause like having a recent surgery or a change in activity level or medication, definitely get checked out by a doctor because it could indicate an underlying condition, a cardiovascular condition, or some other medical condition that needs to be treated. So if you're not used to seeing that number 90s to 105 when you're resting, if this is something new, Even if it's new in the last year, you really want to make sure to get followed up by your physician because that would be considered abnormal or something that would cause possible concern. Okay, there comes another question. Can you drink alcohol in light moderation? Well, I personally say yes, because I do like a pina colada in the summertime at the pool. That's just me. In most cases, yes. Okay, certain medications such as, or certain conditions such as AFib, or if you have congestive heart failure, if you have liver failure or liver disease, you might be a little bit more sensitive to even small amounts of alcohol. Personally, I would think if you have a liver disease, I wouldn't have any alcohol, but that's between you and your physician. So you really want to check with your doctor if you intend to change your alcohol consumption, but I'm not sure that there's any interactions of the alcohol and the medications that we're taking, right? And it should be on your labels. But, outside of AFib, congestive heart failure, or anything related to your liver, you're probably going to be fine, says the doctor. Okay, working my way down here. It's very interesting how he picks and chooses which ones he's going to answer. I think we've done all of these. So time to refresh. So anything going on I need to know about in the chat? Oh,
Yeah, let's
you're
catch up
muted.
on chat.
Let's do that, shall we?
Let's see. Alan notes that also the bone in the chest makes the echo bounce off of it and give you weird readings.
True.
Right?
True. Yeah.
Misty had posed a question here. What's the difference? Dilation and aneurysm. I was told both are the same, and I went and passed that into the Q&A.
Mm-hmm. There is a point where
I can't remember the
just
number.
having
Is
mildly,
that like 4-3?
yeah. I think most, yeah, that's a good point. I think once it crests 4, you can have a mildly dilated at like 3.9 or something like that. They may call it that. But when it becomes an actual aneurysm, I forget how much larger than the normal size, which is dependent upon your gender, your age, your body frame. Yeah. Yeah. Okay. What else?
So then Alan poses, I guess I'm an anomaly. I'm obsessed. Severe high blood pressure, and I mean severe, celiac disease, high cholesterol, and so much more. And like I said, no growth ever. I guess what I'm trying to say is you never really can say what causes an aneurysm in some people or the chances of dissection or growth.
True. Yeah. I think it really will. We may or may not find this out as a definitive thing. I think it does. A lot of it comes down to genetics, right? I have Crohn's disease, so I get you with the celiac. And there were times in my life prior to the dissection when my inflammation markers, my CRP, C-reactive protein, was like 30 something. When normal is like up to 4, right? It's 30. That's pretty high. And all the years I took prednisone and I was on Cipro, I don't think that had anything to do with it. I wasn't on it past 12 months total in my entire life, or maybe 5 times I've received having to take it. I don't think that contributed. But all of the immune suppressing medications and, your heart's working hard, which is reflecting in the CRP levels and genetics. My father had an abdominal aneurysm, and just because someone has an abdominal doesn't mean you can't get a thoracic, right? His mother, my grandmother, detached her retinas, and so did I. So did my sister. So, but you don't think of any of these things, right? You don't think of it at that time of your life. I didn't know I had a slightly enlarged aorta. Thanks so much for the doctors that saw that on an echo prior to a abdominal surgery in 2012 and never told me, or I would have followed up. I would have at least taken my blood pressure meds on time. I always knew to take birth control, but I just thought, oh, I didn't take my blood pressure. I'll take it tomorrow. I just didn't pay attention. I didn't think. Nobody explained to me what the repercussions could be of not keeping that, 145 over 82, which isn't really even technically considered disgusting. But when you have a potential family issue, it's not great. So whatever that 3.9 to 4.2 little aneurysm I had, just decided to go boom one day. But, and that's small to dissect. But it was just, a series of perfect storm events, stress, spikes in those spikes in blood pressure, working out, doing all the exercises, holding my breath, grunting, all of those things you can't, and then having Crohn's disease, can you imagine what it was like for me? There's a lot of pain when you go to the bathroom. I'm just being honest, everybody. So, things can happen. This is just no way of knowing. I would have liked to at least known that I had something with my aorta to begin with. But all right, back to questions here.
Oh,
And then you
hold
can
on.
tell me what.
And so Ryan says, thanks, Karen, Joshua, Dr. Prakash. Time to serve what I've been cooking. So good night, Ryan.
Oh,
Enjoy.
hope you cooked something great.
And Misty says, this live keeps cutting out. We saw a quick drop there for a bit, and
Oh,
then it went
okay.
back to normal.
Okay.
So
Sorry.
sorry about that.
Gremlins.
Yeah, don't know.
Okay. All right. I'm not sure with this question. What is the difference of ecstasies, dilation, and aneurysm? I don't know what that word was. I've heard it, I've heard both for 4.1. Don't know what that word means. Oh, you meant ectasia. Okay, if he thinks you mean ectasia, dilation, and aneurysm, like ecstasies, that's just a typo, clearly. Ectasia means a twisty artery of any size. So if you have a twisty artery, that's ectasia. Doesn't matter what size it is. And another word for ectasia is, oh God, he has to put up words I can't pronounce. Well, I know see, there are words that there's certain words that I've struggled to say. Tortuous, how you say torturous? You say it like that. God, I can't say it.
You're so close. I believe in you. Sure.
Tortuosity.
You're there.
Tortuosity. I'm turning 10 shades of red. Oh my God. It's another word for a harder word. So just go with ectasia. It just means torturous, twisty. Why couldn't he have said it just meant twisty? Why gotta use big Latin-like words? Okay. Dilation means that it's larger than expected. And an aneurysm means that it's so dilated that you would never see that size in a healthy person. Okay, that's a really great way to break it down. All right, so ectasia means twisty. Doesn't matter what size it is, twisty. It has nothing to do with size. It's describing its look, right? What it looks like. Dilation means it's a little bit larger than we expected. It's dilated, right? It's never going to go back down, but it doesn't mean it's going to get larger. But okay, this is interesting. Let's revisit it in a year. Let's just see if it's still dilated. We don't have to worry about right now. If there's no family history, we have a little bit less to worry about. If there's family history, we're definitely going to monitor this to make sure it doesn't become an aneurysm, which means now the dilation is so much that we know we're not going to see that in a healthy person. So now we've crossed into we're absolutely going to monitor this, right? So there you go. In other words, a clearly abnormal and pathological issue. That is the difference between dilation and aneurysm. There's a clear abnormal size, and from a pathology standpoint, it is just not that of what would be in a healthy person. Okay, so it's a matter of degree, just a little bit. Moves it into the next world. Just like for some people, going from 4.8 to 5 is a matter of, are we going to do surgery? It's kind of like, kind of like that. Okay, let's see what else we got. So how come some aneurysms take years to grow and some people's grow really fast? They can grow in a year. Any tips to slow it down? Okay, let's see what Dr. Prakash has to say. So the rate that aneurysms they enlarge really depends on genetic factors, which we've been talking about here, right? Blood pressure and exposure to toxins like cigarette smoke. Cigarette smoking. If you smoke, please, 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 please. I think there's a 1-800 quit now. Could very well be the number. It's in the back of our book. I'll try to look that up. You really need to quit because that is a number one issue next to high blood pressure that can cause you some significant issues. Okay. So tips to slow down aneurysm growth would include lowering your systolic blood pressure to less than 120. That's your top number, right? And stopping smoking, start exercising, and taking medications like angiotensin receptor blockers like losartan, right? And beta blockers to protect the aorta. Those are the things that you can do, that you can control, that's within your control to try to slow down a rate of growth. Okay, next one. Here we go. What are real growth rates of the ascending aortic aneurysm? So based on studies, the growth rates kind of seem slow. However, if you hear so many people needing surgery, so if growth rates are between 0.13 millimeters and 0.35, Most people outside of Marfan's or BAV might not ever need surgery. So that's interesting. So he says 99% of aneurysms never need surgery. It's great, of course. My life, I fall into the 1%, right? Because it blew. But based on recent studies, aneurysms are quite common in the general population. As we've said, dissection's rare and aortic disease, which aneurysms fall under that, much more common. The vast majority of people who have them, again, most people who have aneurysms, they're not going to ever need surgery. So most aneurysms enlarge at a rate of 1 to 2 millimeters per decade. Per decade. That is like nothing growth. Growth is 3 millimeters or more in 1 year. That's when someone's going to say, okay, we have a growing aneurysm. 3 millimeters or more in 1 year. This study is saying they typically happen between 1 and 2 millimeters every 10 years. I love information like this. This is the new stuff I love to learn. This is great. Okay, how long does it take to recover from open heart surgery? So it varies from person to person. It can take as little as a few weeks to up to 6 months, right? I would disagree with the up to 6 months because I think it depends on if you have PTSD, right? That can then prolong having a very normal recovery, right? I think a lot of people are up and moving and doing something probably within 6 months, but whether or not they're recovering emotionally is a whole other story. But that all really depends on your health going into the surgery and if any complications happen after the surgery or during the surgery and your ability to complete cardiac rehab. And if you can't get cardiac rehab with your insurance, your ability to complete some type of physical therapy program. So you really want to talk to your doctor or your surgeon about what would be expected for your recovery time based on your individual factors. Okay. Did we talk about this one? Let me see. We did. Okay, here we go. This person's developed an inflamed right side of their large intestines. The GI doctors think it's ischemic colitis. The vascular surgeon says he doesn't think so, but didn't give much explanation as to why or why not. So this person's sitting here with a painful right side. And the GI doctor thinking one way, the vascular doctor thinking another way, nothing's being done. And do you get a second opinion from another vascular, or do you take another one in it with the current vascular surgeon? And this doctor's opinion is colitis can have many causes. The treatment for ischemic colitis is vastly different than the treatment of other causes of colitis. Excuse me. Sorry. This doctor thinks that you need to establish the diagnosis first, for sure, before you decide on what step to take. And it sounds like that's going to probably require a third opinion. Definitely, third opinion. Break that tie, right? Okay, we talked about that one. So we talked about that one. Talked about that one. Okay, talked about that one, and I think we've talked about all of these. And now we're going to refresh. What's going on in chat land, Josh? As I refresh.
Let's see. Misty asked, would you recommend getting off night shifts if you have a 4.1 centimeter dilation?
I mean, good question to ask, but it depends on what you're doing on the night shift. If it's night shift, do you really notice a difference on versus day shift?
I think that they say that people that work nights have more stressful everything.
Oh, do they?
More stressful on the system. Mm-hmm.
If I were in my 20s, I'd say, well, I'm already up all night, right?
Working is for the young. I agree.
I totally agree.
These child labor laws. No, anyway.
I know, right?
So Alan says, another thing that helps me is that even with high blood pressure, my heart rate is always in the 60s.
Mm-hmm. That is helpful.
And then
that is definitely helpful.
Mine is at 4.2. Laugh out loud.
I'm at like 4.4. So, and mine's usually in the 50s. So yeah. But my blood pressure is really good too. So, but it used to never be. Yeah.
Yeah. Brenny has joined the chat.
Hey, John. Nice to not see you, but know that you're there.
Misty shares with us that her heart rate is in the 80s and 90s most of the time, and sometimes it's just 100 resting.
Is that, again, as what he said, if that's normal for you, if that's been that way, like if you had a dissection, if that's the way it was before, or if that's been the way it's been, then you're probably fine. I'm sure you probably discussed this with your doctor. But if it's something new, definitely say something to your doctor for sure. Okay, we talked about that one. We talked about that one, but I know he just answered one. I just have to try to figure out which one it was. Do beta blockers lower your BP as well as the heart rate? And yes, that is true. Most beta blockers will also lower your blood pressure, but not as much as other blood pressure medications. They're not recommended as treatment for high blood pressure. So it's a combination of things. So all these meds are just like it's like a big chemistry thing, right? You just like play with this one, add this one, a little bit of that one. And, oh, this doesn't make you feel good after 6 weeks. Okay, we'll take that one out. Let's try this one. There's so many out there. And if you ever want to get a sense of how many, you can go to our resources page on the website and scroll down and you will see medications. It's a PDF that was created by Dr. Kristen Watson, who did work for the University of Maryland. She was so great and gave us this information. She usually goes live with us once or twice a year. All of that is also in our book, in our guides, and check it out. It's pretty easy to read and understand PDF. A PowerPoint presentation that she put together explaining these drugs and what they actually do to the body and why we're prescribed them. Okay. La, la, la. Ooh, here's a good one. This person uses cannabis gummies for the PTSD that they had before the dissection and continue to do so once or twice a week, 5 milligrams of THC. Is there any evidence that this could be a problem? Very good question. And there's absolutely no evidence that THC is a specific problem regarding aortic disease. However, please use caution because some formulations of THC may be habit forming and have side effects that limit the efficacy of other medications, such as some that are used for high blood pressure. So please be sure to discuss with your cardiologist or whoever it is that's prescribing your blood pressure medication. Be sure to let them know that you are taking these gummies and give them the formulation. Like just send them over on the portal a copy of the ingredients or how it's formulated or whatever's on wherever you get it. And let them make that determination. Or you can also ask your pharmacist because you want to make sure if you're on a high blood pressure medication that it's not going to reduce the effects of that medication. That's what he means by the efficacy of it. Okay. Let's see where else we are. With an ascending aortic aneurysm, does hypertension add urgency or does it preclude surgery? So hypertension is a risk factor for aortic disease for sure. And it's a risk factor for aortic disease progression, but most high blood pressure can actually be controlled. Most people would try medications to treat the hypertension before you would go to surgery, okay? Because having high blood pressure is a risk factor for surgical complications as well. That's important to know. So the answer is no by itself. The presence of hypertension should not increase the urgency for surgery. Good answer to a good question. All right. Can you have a chiropractor specifically trained to push back a hiatal hernia, push so hard, um, or push that hard with a 3.5 stable aortic dissection nearby? Ooh, that's a really good question. Lots of people ask about chiropractors all the time. And he says a chiropractor actually can't really help with a hernia. He thinks that you should consider seeking another specialist, such as a surgeon or a GI doctor for hernia care. So I have a small hiatal hernia. I have a stomal hernia, and like a a chiropractor's. I don't want them pushing. I don't even know pushing on that. I mean, I've had my colorectal surgeon examine it and has shown me how I can. I know this is gross. How I can kind of push things back in, but has made it very clear if things do not push back in, not the hiatal. Well, it depends on the size, but the stomal, if I can never get it to push back in, I have to go to the ER because you don't want strangulation to occur with hernias. Certain types of hernias, they can actually get strangulated by the abdominal wall, and that would be bad because it could cut off blood supply. So be sure to talk to your doctor, GI or whichever doctor is treating you for the hiatal hernia, and find out if that's something that they would recommend you doing, but it's not really going to be an issue according to him when it comes to your dissection. Because you have to remember, like your dissection is all the way like down around the back. So you don't want them pushing like into your back. And people can still get massages and can still have chiropractors. I mean, I get spine presses, right? I mean, because it's my rib cage is covering and protecting where the aorta is. So that's something to think about too. Okay. And we answered that one. So the statin, rosustatin, butchering, is that better versus the other statin that we talked about? I can't pronounce it. My head hurts trying to pronounce everything. Crestor, that's the name you want to go with when you want to say rosuvastatin. It's Crestor. It's a very potent cholesterol medication as far as lowering your cholesterol, and it causes many more side effects than the atorvastatin. So that's something to think about. Think about if you have questions, you don't feel comfortable with those side effects, talk to your doctor. Okay, we talked about that. We talked about all of those. All right, what's going on in chat while I refresh again?
There was some clarification on whether or not Misty works nights or whether she was talking about nightshades like tomatoes and peppers. I know. Chat's weird sometimes. So
Okay,
she clarifies to say, I work nights, so I'm looking to get off. Would they suggest it? I dislike them. And then she says, thank you for the answers. And she has,
we're getting to that.
I have
Yeah.
naturally low blood pressure, but HR is high. I just don't want to cause any stress on my heart.
Sure. Yeah. Makes sense. All right. Nightshade vegetables and fruits.
Yeah. Chat gets fun.
Yeah, chat is interesting. Yeah, guys have some interesting talks. All right, here we go. We've got a whole new slew of questions that have been answered. Here we go. All right. That's new. That is not the post I want. Back into the one I want. Here we go. Come on, computer. Okay. All right. These are all such good questions. Heart rate is in 80s to 90s most times, sometimes 100 resting. Depending on your level of fitness and your medical history, that might not be unusual. After surgery, the heart rates frequently run greater than 100 and may take several weeks to come down. And then I guess it goes back to the same answer, which is if this doesn't stay as being normal for you, it's something to be talking to your doctor about. And, I think that if you're soon after surgery, and I mean like a year or two, I do think it makes sense to keep a journal and periodically be checking your blood pressure and your heart rate, like in the morning, midday after you take a little 5-minute sit down rest. Do your 3 blood pressures, take the average. That's the right way of doing it, sitting down, preferably with an arm cuff. One that's been validated through validate.bp will tell you all of the preferred um, products that the physicians like. And then take one again at nighttime. Not when you're laying down, doing the same position always, just take one when you're settled at night. This gives doctors a really good sense of where your heart rate is and your blood pressure and how your medications are working. Are they lasting the full 12 hours or 24 hours or 8 hours? Do they need to make any tweaks? It's important to let them know that kind of stuff. All right. We talked about the difference between dilation and aneurysm. We did. Yeah, so this was explained again. It's a matter of a degree. Calling a dilation an aneurysm implies that the dilation is so large that the same aortic diameter could never be seen in a normal person, in quotes. If you say something is dilated, it just means it's larger than you might expect. Okay. AAA, which I believe they're referring to abdominal because that's what AAA means, abdominal aortic aneurysm, is at 5.2 stable. Am I a candidate for surgery? And he says, I can't answer that question because also I don't know if this person means ascending, but that's really hard to answer because surgical clearance requires a detailed evaluation, including a physical exam and going over all of your risk factors, right? So usually you should have a consult with a cardiologist or an aortic specialist or a thoracic surgeon. If it is in the abdominal area, consider a vascular surgeon. There's just way too much unknown information in just that statement for anybody to ever make that kind of a call. All right, we talked about that. So is it true that some new data suggests that bicuspid might be structurally protected against a dissection rather than a risk factor? And what is your comments on the following? Bicuspid aortic valve cases account for less than 2% in IRAD, which is the International Registry for Aortic Dissection, I think. So basically, risk of dissection is very minimum in a bicuspid aortopathy? That's a great question that he did not answer yet, but I thought he did, but I was looking in the wrong place. Sorry. All right. 34-year-old man with bicuspid aortic valve and moderate regurgitation and stable ascending aneurysm. So it's not in the root. It's 4.8, considered early onset bicuspid aortic valve. I'm not too sure what early onset, what that means. Is it considered an early onset bicuspid aortic valve? No. Early onset typically means discovered in childhood. That's what early onset means, or adolescence. The average age at diagnosis of our early onset cohort was 18 years old. So when they did their research about bicuspid valves and its genetic, the possibilities of it being genetic or inherited, the average age when it was discovered or found was age 18. Okay. We talked about the cannabis. Okay, I think, okay. The risk of regurgitation. Okay. What is the rate of dissection for a bicuspid man that has moderate regurgitation and a stable proximal aorta aneurysm of 4.8? Again, that's impossible to answer without more details. In general, bicuspid aortic valves without a family history or any other risk factor, so that means no high blood pressure, no smoking, stuff like that, they have a very low risk, but it varies based on personal and family situations and characteristics. So can't give any definitive answers, sorry. Okay, we talked about that. Oh, is working night shift okay or better to only work days with an aortic aneurysm? So this is an interesting answer. If you have hypertension, like for a thoracic aortic disease patient, that would be a systolic or the top number being greater than 120. Shift work might make it actually difficult to control your blood pressure. The most important factor may be the stability of the work. Switching back and forth from night to day is going to actually be worse for your physical and mental health. So wouldn't switch. But if you're in one, then they're just going to probably switch their mentality from like, if you need more coverage during the night, whereas someone like me needs it during the day, they can just switch that. But if you're switching shifts, don't do that. That's not going to be great. So it could make it difficult to manage your blood pressure. But I think you had mentioned your pressure was good. It was your heart rate that was the problem. So that's interesting. Okay, let's see. Again, the question was not necessarily, you don't have to get off your night shifts if you have a 4.1 dilation. If you have high blood pressure, shift work can make it more difficult and harder to control hypertension. Many young people can do okay with shift work, but it does seem to take a toll. Okay, I think we read all of these. Okay, I'm going to refresh again. I'm going to try to catch up with as many answers as I can before my time is up with all of you. Let's see where we're at. I'm going to take a quick sippy here. Okay, let's see. And remember, he's going to keep going on Facebook at least another hour. So while you might lose me, I know you're so sad, you still have that. All right, let's see what we've got here. I know we have a couple. Talked about that. Okay, the question about the data suggesting the bicuspid might be structurally protective against a dissection. Let's talk about that. So his view would be yes. He think, and I think has come to be the predominant view of most specialists in the field. So for most people with a bicuspid aortic valve, dissection risk is relatively low. Like there would be no reason why people would just have a dissection because they have a bicuspid valve. I think it's when the bicuspid valve could possibly cause an aneurysm, but there's a few exceptions beyond that. Primarily people with a family history of a dissection or a specific genetic variant that could increase the chances of a dissection. So outside of those, they're finding that the potential for a dissection risk is low. Good answer. Good question. Okay. Talked about all of these. So do you know if there's any doctor who specializes in post-op care after a dissection? Interesting. There are several long-term issues that cardiologists don't address, such as residual pain in arms and legs. I would agree. So yeah, physical medicine and rehabilitation specialists can actually assist with care after a dissection. Great question, person. Thank you for asking. Many of those professionals run cardiac rehabilitation facilities and they help dissection patients. Pain medication specialists can help to treat residual pain that happens after dissection or surgery, and they may work with surgeons or cardiologists. I can only speak for myself and say that it shortly after surgery, about 6 months after, I really started having a lot of pain in my right arm. And I realized over the course of a year, it's because I was having a frozen shoulder. So you have to remember, like in emergency surgery, they're just throwing your arms out to the side to strap them down. You're not even aware that this happens. They don't care if they overextend, if they cause a mild small tear. They don't. That's not a priority, right? And I don't really care. But I've never had a frozen shoulder. Um, so that was a struggle for me. In addition, I had no sensation. I had pins and needles inside my right arm. Like, so if you travel down from your thumb, all of this, still to this day, ooh, I get the creepies when I touch it. I can touch it like this, but I can't do the tickles because it still feels like pins and needles. 10 years later, but I had a monster size IV in here, monster size. I got teeny tiny veins and arteries, monster. So I'm not concerned. And it's sometimes it's very common. I started physical therapy before I started cardiac rehab. And here's the reason why. And interestingly enough, I will be interviewing my physical therapist of 10 years. We've interviewed her one time before, but we're going to interview her again. I think it's on April 29th at like 6:30 p.m. Eastern, because I went to her because I needed to do something, but I knew I couldn't sit with proper posture. I couldn't pull my shoulders back because it was still within 12 weeks. Gosh, I couldn't even breathe properly. I was scared to do everything. So I had just seen her and met her 2 months before. She worked on my, I had plantar fasciitis and she did a great job. So I went to see her. She's like, all we're going to do is just breathe. And she took me in a room alone and she just helped me learn how to do diaphragmatic breathing and build confidence that I could take a deep breath in. I had been because I was playing, using that machine. I forget what it's called right now, but I was using the spirometer, the incentive spirometer. But I just needed to just know how to breathe in general in real life, right? So she would work with me on breathing. And then eventually we worked on sitting in a chair, standing up out of a chair, and how to walk with a little bit more posture without hurting the sternum. And we slowly built up to some more stamina, like slowly for 1 minute walking on the treadmill, which got me ready for cardiac rehab because that's all you do the first time is 1 minute on a treadmill, flat, very easy, 1 minute on a bike, and 1 minute on what was the other thing? I want to say it was like a elliptical. I keep want to say eucalyptus. It's elliptical, right? And it was great. By the time I went to cardiac rehab, it was basically the same as PT, except in cardiac rehab, they have you on a monitor. They report back all of your numbers, heart rate, blood pressure. They take it throughout the time that you're doing your exercising. And then they show you videos on nutrition and mental health and different things like that. So if you can't get cardiac rehab, go to PT, but they can really be a great tool in helping you with some kind of pain and just getting yourself started in things. Okay. There- Is there a chance for aneurysms in other areas, including the brain, if you've had one in your aorta? Good question. The answer is the chance for an aneurysm in other parts of the body depends on genetic factors and your family history. So, some genetic causes can also cause brain aneurysms at a higher rate. Um, he said, we introduced gene based guidelines for aneurysms and dissections that explain which genes are known to increase the risk for other types of aneurysms besides aortic aneurysm. So you can get information about that. Okay, what is the rate and risk of dissection for someone who has a bicuspid and has moderate regurgitation and an aneurysm's 4.8? Another impossible to answer, okay, because we don't know if there's family history. We don't know if there's other risk factors. You just don't know. And I think I answered that one, so ignore me. All right, where are we? Think I've done all of these, and I'm going to refresh. We're going to do one more round of this. Anything I need to know about in the chat room? Oh, when I did that, I just opened my eye and let a big hair in my eyeball. Okay, go ahead.
Let's see here. So, did we mention lifting at 4.1? Some say 25 pounds, some say 50 pounds. Doc says 100, but that seems like a lot. I'm not lifting that much. Smiley emoji. Alan says, I love the weightlifting debate. It really cracks me up. You can lift whatever you want if you don't put any strain on you or your or a Valsalva. I just love it when people are afraid to lift 5 pounds. And
You
so,
know,
hold on,
I
lady,
yeah,
hold
go ahead.
on. So I responded because I mean, again, this is still all kind of new data. I go,
Hmm.
Dr. Prakash shared his exercise studies with us not too long ago, and
Hmm.
here's that link. And
Yep.
so, Misty, I would encourage you to take a look at that. That's fascinating.
Yeah.
Um, Much like Alan is saying, it echoes, don't strain. Literally,
Hmm.
that's the goal. But that doesn't mean you
Yeah.
can't work out. So you can increase your strength so long as you're not straining.
Yeah. And I think that the reason that some doctors still say a certain amount, 10 pounds, I've always heard 10 pounds. When I first had surgery, I was told no more than a gallon of milk. And I think a lot of people, when they first come out of surgery, are told very low. Nobody's going to be told, sure, you want to go work out in 2 weeks, have at it. Nobody's going to be told that, of course. Um, but I think it's because everybody's different. If you have an underlying genetic condition that could cause somebody to give you a different number, we've heard one doctor here that's very well known that says, sure, lift 100 pounds. I mean, look, we know that when women pack a suitcase for an overnight, that luggage is probably weighing 42 to 43 pounds. It just is what it is, right? We all put a lot of crap in there. And I pull it out of the back of the car and I lift it up off the curb. And if I have to put it in an overhead, I might not be able to do that, but I definitely am lifting it up on the scale. Usually Terry and I are having a competition who's weighed more. Um, but we're not walking around with 100 pounds all day. You're not bending down to pick something up with 100 pounds all day, right? So that's different. And it goes back to what Alan just said, which is um, I think if you were very physically active before, there's no reason why you can't get back to being physically active again. If you are not, and this has somehow motivated you, I wouldn't jump into doing heavy weights. I just wouldn't do it. Lightweight, more repetition should garner the same result that you might be looking for. Right. But again, you want to talk to your physician. And I would never say lift up to 100 pounds, no issue, because everybody's different. Everybody has their own issues that they experience. But you're right, definitely. I mean, if there's a person to talk to, it would be Dr. Prakash about exercising and what they've done. They did an extensive study using people in this community, people that I'm friends with, that did that for an extensive period of time. So it's interesting to know what those results are, and I'm glad we have that link. All right, here's the question, and then after this round, you guys, I'm outie. But you can always find these answers on Facebook if you're part of that. Okay, so hello, 55-year-old female, type B dissection in 2018, type A in 2021. Marfan, aortic dissection survivor. Surgeon says the person's going to probably need another open heart surgery in the future as they've developed another descending thoracic aortic aneurysm, now measuring 4.8. The surgeon monitoring the chronic uncomplicated indicates that it's growing at about 1 millimeter annually. So the question is, this person wants to exercise more than just walking to be proactive in their recovery for the next surgery. However, she's more afraid of intense cardio and scared that it's going to actually increase the blood pressure and then in turn cause an already compromised dissected aorta to grow faster or worse, rupture. Is this a legit concern, or is this person being too anxious? They read that Marfan patients have a more severe phenotype. And let's see what Dr. Prakash said. So, anxiety about blood pressure during exercise is a very legitimate concern, especially after you've already survived an aortic dissection. So, here's what he tells his patients: you may exercise for an hour a day. During the other 23 hours after you exercise, your blood pressure will be lower than if you stayed inactive. Exercise has also been shown to be safe for dissection survivors and Marfan patients and was shown to slow down the rate of enlargement of aneurysms in Marfan syndrome. Very interesting. I like that line. If you exercise for an hour, the remaining 23 hours, it will actually be lower your blood pressure than if you hadn't done anything, right? So 1 hour of exercise doesn't talk about intensity, just talking about movement, just movement for an hour. All right, lifting while you have an aneurysm at 4.1. Some say 25 pounds, some say 50, doc says 100. Concerned that it might be too much, right? Here's what Dr. Prakash says. You can lift whatever weight you can lift comfortably without straining your chest or your abdomen, okay? We don't want to turn blood in the face, you know? You don't want to do that. You want to be sure to obviously use proper lifting techniques and avoid the Valsalva maneuver, which is bearing down with your breath held so that you turn red in the face again. So you look like you're straining. That's the Valsalva maneuver. So if you're not sure what proper technique is, sign up for a lifting class at your gym or online. It's very easy to learn and lift safely. There you go. Sounds like an endorsement. Okay, let's see what else. If I missed anything, I think I am caught up, you guys. Keep sending your questions, but you're going to have to move it to Facebook now because now I am done. Now I'm going to drink a lot of water, a lot of tea with honey, and try to see if I can get rid of this now after almost 10 days. Thank you guys so much. What amazing questions. I love when I can learn something new because, when you've been doing this a long time, it doesn't happen often. But when it happens, I get so excited about it. I really do. And I get excited when I hear positive answers. I get very icky when I don't like answers, but especially when there are questions that I slipped in on the sly and I'm like, oh, that's a scary answer. But hey, it's the reality of this disease, right? Please don't forget to click like, click subscribe, click the bell, and most importantly, please click share. Share this link on your page because there are other people that you might be friends with in the community, maybe even other people who know that they've had family members who have had this, and they're going to learn something from this. I promise you. This stuff is very interesting. And again, remember, aortic disease is much more common than you think. So thank you again, and I will see you at our next live event. Have a wonderful night. Take care. Bye-bye.